Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Angelini Pharma.
This program is presented by Medscape Education Global.
Hello, I am Mar Carreño, Director of the Epilepsy Unit at Hospital Clinic in Barcelona, Spain. I'm also the President of the Spanish Epilepsy Society. I'm delighted to be joined today by my friend and colleague Bernhard Steinhoff, who is the Director of the Cork Epilepsy Center and Professor at the University of Freiburg in Germany.
Thank you so much, Mar. It's a pleasure to be with you here.
So we are going to talk about the challenges to take care of patients with focal epilepsy, especially the difficult ones. We want to address seizure control, of course, but with acceptable short and long time side effects. And we have also to improve, or at least not to make worse, concomitant comorbidities in these patients. In the next 15 minutes, we are going to use a case and some examples to help you plan treatment strategies to select the right therapies for the right patients and get these people seizure-free. And I said seizure-free. Bernd, can you explain why absolute seizure freedom is something we should attempt in every single patient?
It's crucial, I think, if you're suffering from epilepsy, you're suffering from seizures and from the burden of seizures, and therefore we all know that seizure freedom is the ultimate goal of epilepsy therapy. We know that the quality of life of patients is not really better if we improve their seizure frequency by 8 to 3 seizures per month or something like that. That does not have any impact on the quality of life of those patients. And seizure freedom makes the difference. And in addition, of course, seizures may be dangerous. Consider SUDEP, sudden unexpected death in epilepsy, and that can happen with every single tonic-clonic seizures especially, and therefore seizure freedom is so essential. May I start with a case?
Yes, please, Bernd.
That's Tim. I know him for a couple of years now. That's a 24-year-old with a normal family history, normal development, no comorbidities, a very, very bright guy. And 4 weeks prior to his graduation, he got this terrible encephalitis at age 17. With a duration of 8 weeks of intensive care, intermittent status epilepticus, everything was done, but it was very difficult and the outcome was pretty miserable with the bilateral hippocampal sclerosis, a severe cognitive decline, especially of memory, and the onset of a focal epilepsy. His seizure semiology is peculiar because he had several types of seizure with the déjà vu-like feeling, epigastric uprising sensation associated with heat, occasional unawareness, oral elementary automatisms, no irritability, and an occasional head version to the left. And he has also abrupt losses of consciousness with staring, tachycardia, and severe decrease of oxygen saturation as well. Finally, with a tonic-clonic phase and often status epilepticus, and also abrupt tonic stiffening with falls and very severe injuries. His EEG showed continuous slope, theta-delta, sharp waves, intermittent temporal and frontal bilateral independent. We did a lot of video EEG and recorded about 40 to 50 seizures and showed clearly a multi-regional origin of those. And In line with that, MRI showed a diffuse cortical atrophy, bilateral hippocampal sclerosis, and severe bilateral insular lesions as well. So that's the question here. In that case, with this abrupt onset of focal epilepsy, how are the chances of this patient to achieve seizure freedom? And we know from the literature, of course, we would give 1 or 2 anti-seizure medications in a given case. With the 3rd or 4th anti-seizure medications, the chances are reduced dramatically. And in this case, I'm showing to you, we have the additional lesions and multiple lesions, so the a priori chance to achieve seizure freedom is certainly very low.
So when we have a patient with the onset of focal epilepsy, how would you choose the therapy? I mean, we could follow several different paths. We could follow randomized double-blind controlled trials that, of course, offer a very good evidence, but however, these are performed with a drug versus placebo. We have very few head-to-head comparisons, and the type of patients included in those studies are very selected and very peculiar. Do we use more pragmatic clinical trials, open label? Do we use all the evidence we collect when we use these drugs with our patients in the real world? Do we follow national guidelines? And we know many guidelines are already outdated in the moment they are published, and there are lots of differences sometimes regarding recommendations between different countries when economic factors, for example, are taken into account. So what do we do, Bernhard?
That's a very complex question. And you mentioned guidelines. That's one of my favorite topics. But I will come back to that later. What we have is the SANA trials. That was a sort of real-world comparative trial with Tony Marson as the first author. And from those trials, we know that considering focal epilepsy, lamotrigine was the winner. If we consider both efficacy and tolerability. So from the beginning on, at least in my country, lamotrigine, due to the SANA trials, is now the first-line anti-seizure medication. But the question in my case is it really realistic in a guy who has frequent seizures every day, tonic-clonic seizures every day, to start with a drug like lamotrigine, although the national guidelines go for that? Well,
probably not, among other reasons, because it takes a long time to up-titrate the therapeutic dose of lamotrigine, no?
Yeah, absolutely.
And you are right. I mean, this particular patient looks like he's probably going to become drug resistant, because there are studies showing several clinical factors that are associated to the development of drug resistance. And this patient has many of these factors: high seizure frequency from the very beginning, structural lesions in the neuroimaging, abundant multifocal epileptiform activity, interictal and ictal. So yes, we can assume he is going to be a difficult type of epilepsy. So perhaps we need to consider other ways to treat him fast and with very efficacious drugs.
Absolutely. And do the guidelines really help in that situation? Well, we have some guidelines available, like the guidelines from the International League Against Epilepsy, but those were published based on class 1 evidence-based trials and more than 10 years back. That doesn't help us nowadays with all the new recent drugs we have. Then we have the NICE guidelines that are very much more updated from the United Kingdom, and we have other guidelines. I mentioned our national guideline from Germany, and NICE and the German guidelines are pretty much the same, because we go for lamotrigine, NICE also for levetiracetam, and The algorithm of our guidelines shows clearly that whether it's lamotrigine in our case or another drug, probably another drug due to the drawbacks of that case, we have to go for a consequent monotherapy, and after that monotherapy, if it fails, it is allowed, at least in my country, to go for a combination or an alternative monotherapy. What about in Spain?
Well, in Spain, of course, the physician can choose whatever option, but some years ago, we asked our colleagues what could they do if a patient on a monotherapy continued to have generalized tonic-clonic seizures, and most of the respondents, this was a study with a Delphi methodology, chose to add on a second drug to the first monotherapy because of the severity of generalized tonic-clonic seizures and indirect evidence that the efficacy of this approach in spite of perhaps worse tolerability. So that's something we can do. I mean, go early to a bitherapy if we think the seizures are severe enough.
Now, in our case, levetiracetam was started. We stand at that patient's bed and the parents are with him and they ask you to do something. So levetiracetam with a rapid upward titration to 3,000 milligram had almost no effect. And then we added lacosamide because we wanted to have an interaction-free, powerful sodium channel blocker up to 500 milligram per day, but we had almost no success. So we have the question, how do we proceed now? And once you decide to add on, how do you choose? Well, again, here we have the NICE guidelines with the first line established or more established anti-seizure medications and the second line ones. Some of them are the more recent ones like brivaracetam or cenobamate or perampanel. And since we need effective drugs with a high efficacy in a case like Tim's, it may be correct to ask the question whether the second and first line ranking is still the right order. So does this reflect really what you do in practice? And in some cases, it's certainly not, and it should not the case if we look for efficacy.
Because now we have some evidence coming from a meta-analysis, no real comparative trial, but in this meta-analysis by Simona Latanzi, comparing the results of the trial of cenobamate with other drugs that have been marketed during the last year, such as slicarbazepine, brivaracetam, lacosamide or perampanel, cenobamate seemed to be superior in terms of efficacy.
Well, in our case, of course, we had several options, as we said. And after this levetiracetam and lacosamide, and still in combination because we were frightened to reduce levetiracetam, we had several options, including most recent anti-seizure medications due to efficacy, such as cenobamate or perampanel or topiramate or even brivaracetam, speaking about efficacy. But what about tolerability?
Well, regarding tolerability, and mentioning that study I just was referring to by Latanzi, they also compared in the different trials the different tolerability profiles. And in this case, there are some drugs that seem to be better tolerated, and these are brivaracetam and lacosamide, which your patient is already on lacosamide. How do we consider tolerability? Well, tolerability is a very important issue in patients who are going to be taking this drug long term. Of course, we need to consider different types of side effects. On one hand, we have the dose-dependent central nervous system related side effects that are very common, and we are really used to dealing with this type of side effects. We can also have long-term metabolic side effects, which may be relevant for the patient long-term. And then we have specific types of side effects that really can concern a lot the patient and the family, and those are the psychiatric side effects, which have been very common in some drugs that have been in the market over the last years, and the cognitive side effects, very important for patients that very often have already pre-existing cognitive deficit as your patient. And of course, we need to consider if teratogenicity, no? That we used to consider basically a female issue, but now with the warning with valproate and male, well, there are some drugs such as valproate or topiramate we really need to be aware of if the patient is young and want to have children.
Yeah, well, I totally agree. It makes it more complicated, of course. Perhaps retention rate is quite a good outcome measure because it combines tolerability and efficacy. And well, in our case, we went for cenobamate first because we have our monocenter data showing that retention rate of cenobamate was quite good. We didn't give piracetam because he was not a levetiracetam responder, and we didn't give topiramate because of a neuropsychological profile. But well, our data, our monocenter data, show that retention rate with cenobamate was very high. On the other hand, perampanel and cenobamate were extremely effective and very similar to the data of Simona Lattanzi. The tolerability of lacosamide and brivaracetam was better than that of perampanel and cenobamate. So you always have to judge in the individual case what is the best individual treatment. And well, in our case, of course, we had to consider how to manage a third anti-seizure medication and how to go for a better retention in terms of, well, lacosamide 500 milligram. What would you consider?
Well, we go very slowly with cenobamate in terms of titration. That's what we have to do to avoid a rush, to make it less likely to happen. And because it acts partly as a sodium channel blocker, and we are going to combine it with another sodium channel blocker, which is lacosamide, we need to decrease normally the dose of lacosamide when a therapeutic dose around 150 is already reached with cenobamate, and we've had this impression, and we put it into a paper that is going to be published in the next months in a Spanish consensus. So sometimes tolerability is a matter of adjusting the doses of concomitant medication. In the case of cenobamate and high doses of concomitant sodium channel blockers, it's common that we have to decrease or withdraw completely the other sodium channel blockers to be able to increase the dose until really effective therapeutic doses of cenobamate.
So in the end, we have to consider that we are speaking sometimes about a lifelong therapy, and then of course tolerability is a very important issue, right?
It is. Well, this has been the discussion of our case. I think there are some points we can take home. One is we should try to get every single patient seizure-free. For some it's not going to be possible, but we really must try hard to achieve seizure freedom because, as you mentioned, is going to improve their quality of life significantly. The choice of medications have to be done by efficacy, tolerability, and the particular circumstances and comorbidities of each patient. And of course must be adequate to the type of epilepsy and epilepsy syndrome the patient has. We have plenty of anti-seizure medications nowadays. We should be able to find the best one for a given patient. Sometimes not the guidelines, not the randomized double-blind clinical trials are going to be able to give us the answer. So we must use indirect comparison, real world experience to guide us, and we need to become familiar with all the new anti-seizure medications because they can benefit a significant number of patients in the short and in the long term. Thank you for your attention, and of course, thanks Bernard for accompanying me here.
That was wonderful again.
And please don't forget to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.